Well, thank you. Yes, thank you, Laurence, for helping me with this introduction. Actually, Laurence and myself, we asked Tom Cruise to come over, and unfortunately, he was not available. He would have come with pleasure, and he apologizes. So we have to do it. So Laurence made the sound. I made the words. And well, this is my hospital. This is how it was 100 years ago. And we just through this one century of the department. The first head of the department was Antoine Leclerc, who built the department in this hospital. And this is where it is. And this is now, but this is the front face. But if you look behind this building, it is exactly the same. It doesn't change at all. There is a slight change with the title. In the title and in your program, there is no question mark. And now there is a question mark. Why is there a question mark? Because it's not a mission impossible. But first of all, let's see the problem. After that, the tape will be erased. Finally, definitely. The WHO said a few years ago that by the year 2010, HCC will surpass lung cancer as the foremost cause of cancer mortality. You should, like Woody Allen says, that it's very difficult to foresee the future, especially when it is to come. And the WHO was wrong. It's not the first. We have passed 2010. It is the third now, but the third is something, and as usual we have more information from the US. In the US it's the 9th leading cause of cancer death, but what we know is that the incidence of HCC has increased from 1.4 to 2.4, it's almost double, which is important, it's almost double all around the world. And what is interesting and is important is that even in a country like the US, if we think that there are something like 5 million people with chronic viral hepatitis, most are unaware of the disease and will develop hepatocellular carcinoma in a very silent mode. So this is important for the understanding. So your mission, what is your mission? Your mission is number one, to detect and characterize the HCC. Number two, to stage according to the optimal treatment that is available in your facility. And third, to evaluate the treatment. Like in all missions, you have enemies. One enemy is the mimicus. The other one is the terrible family, which is the family of the mafia, which is the nodule family. And the third is the mutant, the aliens, the variants. So you know your enemies. But sometimes your enemies are from inside, and you have two not so good friends. The biopsy and racist are not your friends, not all the time. But you have weapons. One weapon is MRI, it's technical. The second is free, it's patience. But it's time to convince a patient to be patient. And third one is history, and you have to be interested in history. These are your weapons. So let's face our enemies. Our enemies are the mimicus. First of all, is focal steatosis. It seems to be very stupid. It's very common in patients with alcoholic situation, but also in other situations. And always, this is interesting, when we have a deep fibrosis, end-stage disease, there is no more steatosis. Steatosis is the disease of the early cirrhosis, not of the late cirrhosis. So this is a case with a patient with heterogeneous liver, several nodules. This is after a gadolinium injection. This is a mass, this is a mass, and this is an in-phase and an out-phase imaging. So be careful, because in-phase, out-phase imaging will really nicely show you the difference and say, well, that's fat, don't worry. However, be careful, because a significant percentage of hepatocellular carcinoma contains fat. So the presence of fat does not eliminate the possibility of HCC. And I think it might be very interesting for you to see that there are normal vessels within it. Normal vessels within HCC, it's impossible. Normal vessel within steatosis, obviously this is possible. The second mimicker is confluent fibrosis. Confluent fibrosis presents usually as mildly hyperintense T2 area, mildly hypointense T1 area. It presents with variable earlier enhancement, and these are rotten signs. But the good signs are, first of all, the delayed enhancement of this area. When I see delayed, it's 2 minutes, because I don't have the patience to wait for more than 2 minutes. The second is the geographic contours. This is probably Tom Cruise calling. And the third one is the capsular retraction. If you have the 3 signs in the same place, you are pretty confident that this is confluent fibrosis and not infiltrative hepatocellular carcinoma. No biopsy. Third mimicker is arterioportal shunt. So this is very easy in large cases. This is a triangular area. There is a small portal radical seen at the arterial phase in the middle. This is post-biopsy, so this is radiologically induced arterioportal shunt. This is easy. But when we are facing small arterioportal shunts, it's maybe more challenging. So they are capsular-based, they are triangular, they homogenize at all phase, and this is very interesting. But which is more interesting again, if you are patient, if you wait for some time, they are usually stable over the time. So time is your friend. Future is your friend if you have the patience to wait for the future. Let's face now the aliens. This is November 2005. This is a patient with chronic post-viral cirrhosis. This is December 2006. Same patient, same liver, but this thing lights up. So this did not exist. It's also an arterial phase, a rather good arterial phase. This is an arterial phase. Okay, so we go to the multidisciplinary team, and the decision was to make a resection, surgical resection. Why do I take this examination from 2005? Because at that time we had no PACS. And the reality was slightly different. When you are in a multidisciplinary team, you know that you have to report on images. You don't even know where it comes from. There is one film, one place, another image popping up, and you need to give up information really fast. And therefore, the lighting up nodules appearing in a liver with the cirrhosis, small one, this is a case for surgery, or radiofrequency, but we have chosen surgery in that case. However, the reality is that this was not the truth. We did not realize it, because in the heat of the multidisciplinary team, we just thought that something lighting up could only appear, and nobody has looked at the time of the images. Okay, so this did not appear, this disappeared, and this is different. However, by the time we realized that this disappeared and not appeared, the patient had surgery. And what was resected was just a regeneration nodule. The reason why this regeneration nodule, slightly hemorrhagic, that's all, was enhanced, nobody knows. But the regeneration nodules are living people. They appear, they grow, and maybe they die. And as everybody, they are teenager. And where they are teenager, developing, growing, they do just like our teenager. They do anything but the right thing. And what we can do is to enhance because they need to develop. And this is one possible explanation why we have some important things. And this is what I call also the UBOs of the liver. This is not a minor problem, this is a major problem. What we know is that among this nodule, that enhancing nodule, these enhancing nodules, we know that at least 50% will be no longer visible on repeat imaging. Just check the dates of the examination when you are comparing. 50% are not anymore. And we know also that 80% of these enhancing small nodules are not hepatocellular carcinoma. Can we guess which one are not? No. And this is the reason why we have guidelines. And this guideline is a combined guideline between the AASLD and the EASL. And this says that we have to behave when we are looking at nodules. And when we are facing at small nodules, the recommendation is to repeat the ultrasound at 3 months and see if it grows or if it's stable. If it grows, should be investigated. If it's stable, go back to update. This is what is in the literature. This is not my recommendation. I will show you now one case. This is a patient with a cirrhosis C. And 1, 2, 3, 4, 5 UBOs. Which one is cancer? Which one is not cancer? And the answer is patients. Patients do the same examination, and not ultrasound. How can we find out ultrasound these kind of images, and wait for a few months? This is November, and this one is HCC, this one is HCC, this one, and this one have disappeared. You have no possibility, virtually no possibility today. We'll see later that we may have some possibility, but we have no possibility to guess which one is hepatocellular carcinoma. Patients, same image, same technique, same machine if possible, if you are referring to MR, that's important, and probably same radiologist 4 months later. So my strategy is slightly modified. If I have a hypervascular lesion less than 1 centimeter, first of all I'm looking for previous examination. History. History is your third friend. If you have no previous history, follow up, same method, 3-4 months later. If you have previous history, are there any changes? If not, go back to follow up. If yes, you take the decision to the evolution. Look at this case. Small, hyper-enhancing nodule in the liver. Arterial phase, portal phase. We even have 2 ancillary signs, which is the washout and the rim enhancing. However, it's very small. According to the AASLD criteria, we have to wait a few months. However, if we look at the history, you can see that finding back this image, there was something enhanced. And this is an evolution. You don't have to wait. History is your friend. Look for history. Try to look back at the images. If the images are good, if they are similar, if the technique is all right, changing are valid. They are important for the decision. Now let's go to the mafia nodule family. They have fathers and cousins, just like in every mafia. But we have to go a little bit further in the analysis of this family. Because not everybody is the father, not everybody is the son, not everybody is the cousin. Briefly, when you have a liver damage, there is a destruction and a regeneration. And regeneration is, and is exclusively, regeneration nodules. However, During regeneration, sometimes you find genetic alteration. Genetic alteration lead to a dysplastic cell and lead to dysplastic nodule. And later, if this is a severe genetic alteration, due to the influence of angiogenesis, it goes to HCC. So there is a missing link. Is there a link here? No, there is no link. Regeneration nodule, dysplastic nodule are cousins. They have the same grandfather, but they are not father and son. So the regenerating nodule on one side, the other nodule on the other side. There is no reason that regeneration nodule would lead to hepatocellular carcinoma, excepting that both are the consequence of cirrhosis. Can ultrasound do something? Unfortunately, not much. On ultrasound, if you get a high frequency probe, you can see that there are some alteration of the structure. This is what we call the course pattern. You see the nodule, which is underlined by the annular fibrosis. And if you look at the anterior aspect of the liver, you can see the very typical nodular contour. If you have time to do that, you are looking for enhancement with ultrasound, and this is important. However, not everybody is performing it. And you can see this is very typical of hepatocellular carcinoma. However, the sensitivity for very small nodules and the specificity for multiple nodules is quite low. But this is a very important Does CT help? No, not much. On plain CT you have hyperintense nodule. This is probably related to the iron content, maybe iron content. They are not hypervascular, and in many cases they disappear at portal phase. Your friend is MR. Let me show you. This is a patient with a regeneration nodule. Regeneration nodule are hypo everything. Hypo T1, hypo T2. Or ISO. ISO you don't see them. They are hypovascular. They do not enhance. And this is important. Black, black, don't see them, don't see them. Diffusion weight imaging doesn't see them. The dysplastic nodule, the cousin, with the bad guy. This is the bad guy. They are found in 25% of the patients with cirrhosis. How do we see them? Typically, very typically, we see them at hyper-intense nodule on T1, ISO or hypo-intense on T2, and no enhancement. Be careful, this is not because it's white on T1 after gadolinium injection that it is enhancing. If you compare it with the plain image, it does not enhance. And obviously, no washout. Hyper-intense T1, ISO or hypo-intense T2, no wash in, no washout. Finally, the very bad guy is the hepatocellular carcinoma. We can detect it with MR, we can detect it with CT. Is it better to perform CT or to perform MR? It's absolutely clear today that MR is superior, clear. When you go from CT to MR, you improve the detection rate by 10 to 15%. CT is not bad. It's not optimal. So finally, if we want to classify the important sign and try to differentiate the regeneration nodule, the dysplastic nodule, and early HCC, what is important in is enhancement. If there is enhancement, it's HCC, it's not dysplastic nodule, it's not regeneration nodule. Remember the case I showed you. This is statistical. It does not apply to very individual cases. And hyperintensity on T1 may make you think of dysplastic nodule. It works a little bit. Look at this patient, December 2008. Dysplastic nodule, they are hyperintense on T1. You don't see them on T2. They do not enhance. We said plenty, a bunch of dysplastic nodule. We even had a biopsy showing that it was dysplastic nodule. So we know that this is the bad guy. And we know that this bad guy may give birth to hepatocellular carcinoma. So you have to follow up this patient. Be careful. Everybody believes that you will have the hepatocellular carcinoma in the place there are dysplastic nodules. No, no. You can only say that this patient may have a high risk of hepatocellular carcinoma anywhere, because you see a bunch of dysplastic nodules. There are probably many more that you just do not see. So try to guess where is going to be the hepatocellular carcinoma, left lobe or right lobe. This is diffusion-weighted imaging. Right lobe, which is not the place where most of the dysplastic nodules work. So remember that if you say that the patient has dysplastic nodule, there is a high risk, but the risk is everywhere in the liver, and not only in the place you have seen the dysplastic nodule. Okay, so this is T2, this is diffusion. After that, well, one of your goals will be to evaluate the milling criteria. If you work in a center where you perform liver transplantation, your question, number one, is this patient eligible for liver transplantation, yes or no? So you need to be familiar with this Milan criteria. Either one lesion less than 5 centimeters or up to 3 less than 3 centimeters. So the differential between these nodules is challenging, very challenging. So sometimes we may have new friends. This new friend is the liver-specific contrast media. We call them the hepatobiliary agents, and there are two. One is the multi-hands, and the other one is the primavist. They can serve as extracellular agents, so you can perform reasonably good and very good MR imaging with dynamic phase with both. They have hepatocyte uptake and biliary expression, and they have an epitheliary biliary phase. So the difference between the two is one. If you are using multi-hands, you need to wait an hour, and preferably 3 hours, before you can have the hepatobiliary phase. It works, it takes time. So from the organization point of view, it's difficult. For gadoxetic acid, which is the primavist, you just have to wait 20 minutes, and I will show you my protocol. How does it work? This is a regular hepatocellular carcinoma, wash in, wash out, capsule. Hepatobiliary phase later shows absence of enhancement. Hepatocellular carcinoma in most cases does not enhance on hepatobiliary phase. Let's see a case of dysplastic nodule. This is a very big one. No enhancement at arterial phase, but enhancement at the hepatobiliary. These plastic nodules are still functioning, but they uptake the contrast. Look at this case. This is at the hepatobiliary phase, enhancing nodule. This is not hepatocellular carcinoma. There is no arterial enhancement, and this patient has just a small regeneration nodule. This patient has 3 hepatocellular carcinoma. Enhancement at the arterial phase, enhancement at the arterial phase, enhancement at the arterial phase, however, no washout. According to the ASLD criteria, you should make a biopsy. If you inject this contrast, you can see that none of this lesion has taken the contrast at the late phase, and this is multinodular hepatocellular carcinoma. No biopsy is necessary. So we need to add a line on our differentiation between the nodule, which is the hepatobiliary phase. Uptake is clearly regeneration nodule. More or less uptake is dysplastic nodule. No uptake is hepatocellular carcinoma. And this is important. So this is my protocol. If you are using Primavist, 20 minutes enhancement, therefore you inject immediately and perform the T2, the diffusion-weighted imaging after that. And therefore you takes you 20 minutes, and the total of the examination is 35 minutes, not too bad. If you are using the multi-hands, you do a regular MR, but you have to get the patient out of the machine and calling back at 2 or 3 hours, which might be difficult. We may also have a very simplified protocol. For some cases that are clear, for instance, if you want to perform the follow-up of radiofrequency, chemoembolization, follow-up of sorafenib treatment, just make a 3-point Dixon T1, which provides you the images of fat saturation, which is the water selection, in phase, out of phase. DWI, which will provide you with the T2 signal when you are looking at the low B images, an injection, and that's it. And this is no more than 60 minutes from the beginning to the end. Does WI or WI help? Not really a lot in the detection of HCC, but if you want a simplified protocol, B0 images will provide you as a substitute to T2 images. And what is new is that probably nodule with restriction of DWI, when the hepatocellular carcinoma is hypovascular, these nodules are more keen to become hypervascular later. And this is a paper by Kim, a quite recent paper, showing hypovascular hepatocellular carcinoma. But if you are waiting for some time, those who have a restriction, initially a restriction, if you waited images, will become more rapidly more aggressive. This is preliminary, it needs to be confirmed, but this may be interesting. DWI will not help you to detect, DWI may help you to evaluate the invasiveness, if possible, invasiveness of the tumor. Let's go to some simple situation. It will provide you the need for a biopsy. Why is biopsy your enemy? Because we have a high proportion of seedings. And sometimes the pathologist will not even be able to tell you what kind of disease it is. So if you can avoid it, do it. Simple. Wash in, wash out, capsule. 70% of HCC are encapsulated. You absolutely don't need a biopsy to confirm the diagnosis. Second situation, mosaic pattern. This mosaic pattern is very specific. No need for a biopsy to make the final diagnosis. Nodule in the nodule. This is a big, probably dysplastic nodule. This is a small enhancing nodule. No need for a biopsy. This is a dysplastic nodule. This is a hepatocellular carcinoma. As much as you can avoid biopsy, avoid biopsy. Staging. Staging is important, but it's not limited to the extent of the disease. You have to track the early sign of vascular aggressiveness. Biliary invasion, vascular invasion, extracapsular invasion, and obviously extrahepatic disease and severity of the disease. It's easy in some cases because you have a big tumor and you have a big bud out of the tumor. But sometimes it's more challenging. Look at this small image, very small. This is a case for surgery. According to the criteria, you should perform a resection of 1 centimeter around the tumor. However, look at that, look at that, look at that, look at that. Look at the capsule is broken here in one place. This means that there is extracapsular invasion. And look at the surgery, the tumor, nodule, 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 HCC, just like we saw it. Please be attentive to look at peripheral, very small enhancing nodule. Otherwise, when the surgeon will do it, when the interventional radiologist will do radiofrequency, it will miss because there will be a recurrence at the periphery of the tumor. Everything which is peripheral, sometimes linear, which means the vascular invasion, is extremely important to stage before you decide for surgery or any other treatment. And obviously, You have to look for extrahepatic disease. Look like this patient, a very big tumor. He comes from China. He had a resection. So what do you think? What would